Naveen. Naveen, मलाई सुन्छौ? सुनिन यार तिम्रो।
बस
हजुर
wait Subhas?
हजुर
Sorry, I was muted. Yeah.
हो अहिले ठिक छ?
Timro, do you have share screen there so that later on problem no was?
है त एक्ज्याक्टली शेयर कन्टेन्टमा प्रेस गरौँ है।
Okay. We'll start. Anyone who comes can join in. Like anyone who has not muted it, at least apart for presentation, apart from presenter, please try to mute it. Namaskar, good evening. Nepal good morning. As a session, we will be doing on toxiderm, acute intoxication and poisoning. As a moderator Dr. Promise Shrestha हुनुहुन्छ आज अनि Dr. Subhas Regmi चाहिँ US बाट presentation गर्दै हुनुहुन्छ mainly before we start I just wanted all of you to know that ANMF critical care forum चाहिँ हाम्रो अब म Dr. Kaini अनि Dr. Subhas Acharya, Dr. Raju Centuryहरू भएर we started this initiative around 2.5 years ago हैन अहिले we've done these sessions for the almost monthly for the last 2.5 years and it's been well received from both sides here as well as in Nepal, and we have these ongoing discussions on topics. Sometimes we discuss cases from Nepal, sometimes we have different presentations from Nepal, and sometimes from United States. So if there is anything like this topic let us know. For next month, I just wanted to let you all know we are part of America Nepal Medical Foundation, and next month we are having 28th annual general meeting in Chicago, and I think that's part of like we always try to collaborate with Nepalese healthcare workforce and we are part of collaboration committee, and we always try to build more things so that we can exchange knowledge and learn about how it's practiced in Nepal and all of it. So that's a great opportunity. And I think from our end, Dr. Subhas has been pivotal in this part, and we always thank him for this. And today, without further ado, I'll let Dr. Pramesh hand it. I'll have Dr. Pramesh take it from here. And if there is any question, you can put it in chat box. Otherwise, we'll entertain it at the end of the session. Thank you, Dr. Pramesh.
Thank you. So I think we have Dr. Subhas as a presenter today, and he's a consultant. I think he's done nephrology and he's doing critical care, and he's currently practicing in University of South Carolina. And I think he's done his bachelor from Nepal Medical College, when it was in early phase. So I think he's going to enlighten us about acute intoxication and poisoning. And I hope that this will be a fruitful session. And we've got peculiar type of poisoning in our setup. So I think as the interaction progresses and the lecture progresses, we'll have more interaction, and I think we'll share our knowledge. So Dr. Subhas, please.
Hazur, thank you, Dr. Pramesh. Thank you, Dr. Naveen, Dr. Subhas, and rest of the audience. मेरो नाम सुभाष रेग्मी. I'm currently practicing critical care and nephrology, and today I'm going to give like a brief overview. I mean, I'm trying to include a lot of topics, but I'm just trying to give a brief overview. First of all, before I start, can everybody hear me? Naveen,
yes.
Am I clear?
Yes.
Okay. Any noise, anything?
Loud and clear.
Okay. Thank you. So let's go into our objective of the meeting. Just a second. So today the objective of this presentation is to review our basic fundamentals of pharmacokinetic and toxicology, and then identify clinically significant toxidrome, and then we are going to talk more about like individual toxins and antidotes. And then finally, I would like to finish up the presentation with the role of extracorporeal therapies, including dialysis, even up to ECMO support. So briefly, history-wise, Paracelsus, born Theophrastus von Hohenheim, a Swiss physician from like early 14th 15th century, is regarded as father of toxicology. And I would like to include this quote, which is, I think, very relevant in all aspects of our life, which is like, all things are poisonous and nothing is without poison. It's the matter of dose, which permits something not to be poisonous. So brief, so I know Dr. Promise mentioned earlier that we will be talking in the group about in some aspect of poisoning which we see more in Nepal, and there are some aspect of poisoning which we see on this side of the world. And this stat, it's mainly from here, so it may not be exactly 100% relevant, but just in general, like, the interesting thing about poisoning is, there's a lot of poisoning happens every year, and a lot, like, almost 9 out of 10 happens at home. But the good thing is that, case fatality is luckily less than 1%, and maybe 1 out of 10 maybe intentional attempt. And before we go into details, I just want to include a few points. Is that not all patients with presumed overdose have in fact overdosed, meaning that, like, you get called from ED saying that, hey, I have a patient altered, or like, with hemodynamic imbalance, and ED thinks that patient has overdosed. So, but before, like, we go full blown about, yeah, this is all overdose, we have to keep in mind, we need to keep in mind the differential diagnosis, right? If someone is, acutely altered, there are so many other reasons to be altered. Like, you think of intracranial cause, extracranial cause. You think of intracranially, is this a trauma? Is it a stroke? Is it a infection? Seizure, post-ictal, or finally, yes, maybe it's truly overdose. So we have to keep all those things in mind. And the second thing is that a poison patient may have suffered a secondary event, meaning that the patient, after the exposure to the toxins, may have developed acute stroke, may have had aspiration leading to aspiration pneumonitis. The patient could have suffered acute coronary syndrome post exposure to the toxin. So we have to keep those things in mind. And always, there is always going to be a lot of times, in general, polypharmacy. It could be like multiple different toxin ingestion, like starting with alcohol, toxic alcohol, or like, nowadays, like, we see that, in general, patients are taking multiple medications. So, in presence of acute kidney injury, even those multiple combination of medications could end up being a toxin. So we always have to keep in mind that polypharmacy is the rule. And last but not the least, poisoning is not always oral. It could be from different routes, like inhalational in case of your carbon monoxide poisoning, cyanide toxicity, or even dermal. So, going back to our good old days of pharmacology, where we read about pharmacokinetic, basically, which means that what body does to the drugs, right? Pharmacodynamics is what drugs does to the body, but here we are talking about what body does to the drugs. And it starts with absorption, and then, like, once it gets into the blood, it gets distributed. Most of the time, it gets bound to your protein, albumin, and then gets metabolized in general in the liver, and then excreted via liver or kidney. This is our, like, general pharmacokinetic. And in terms of like toxic ingestion, toxicity, the important thing is that since there is a lot of that compound, a lot of the drugs going into the system, and what happens is there is an increased bioavailability. There is going to be increase. There is going to be the proteins are saturated. So that's where like your concentration level gets high. I mean, it's a basic thing just to get like a reminder that yes, I mean, there is increased bioavailability, increased concentration, the plasma proteins are saturated, and that's where you start to get into that toxicologic dose. And in general, metabolism, I mean, we all know liver is the principal site. I mean, we have read about cytochrome P450, which is like a major metabolic enzyme in the liver. And then like first pass effect, I mean, this means that first of all, when the drugs gets absorbed, it goes via your portal venous system to the liver, and in liver it gets metabolized, which basically is first pass effect. And then after metabolism, like some of it gets excreted in bile, or they may end up in the circulation also. And the enterohepatic circulation, just to give you a brief overview, is that in this case, what happens is once that compound is metabolized, it gets excreted in bile, it gets reabsorbed. So it goes in and in, I mean, like further multiple times into your circulation. And this is important in few overdose situations, such as barbiturate, carbamazepine, who goes through this enterohepatic circulation. And I'll talk about the significance later on, and why this is important, what's the role, I mean, why we talk about activated charcoal, why we talk about multiple activated charcoal dose, just to eliminate this step. And finally, excretion, like, I mean, via multiple routes. So let's dive into our toxidromes. All right. So what is a toxidrome? So basically, toxidrome means that a common like clinical presentation by acting through a common receptor, but different classes of drugs, different classes of medication, which goes through one similar pathway, and that individual like pathway, we basically label it as a particular toxidrome. So it could be anticholinergic, cholinergic, adrenergic, all the way to our opiate toxidrome. So we'll just briefly go over these scenarios. So anticholinergic, I mean, again, going back to our pharmacology days, right? I mean, so we have read about our, I mean, autonomic system. We read about sympathetic, parasympathetic pathway. Now, I mean, sympathetic pathway basically involves your alpha and beta receptors, which are activated by norepinephrine, and your acetylcholine receptors, which are basically muscarinic receptors activated by acetylcholine. And then your nicotinic receptors are present at your neuromuscular junction, as well as those nicotinic receptors are present in your preganglionic, both sympathetic and parasympathetic pathway. So nicotinic is present both, but your muscarinic is present primarily in your parasympathetic postganglionic pathway. So whenever we talk about anticholinergic toxidromes, so we are talking about primarily blockage of these muscarinic receptors, leading to multiple different side effects, as well as role of nicotinic receptor blockade in our preganglionic primary CNS pathway. And the reason I'm talking about anticholinergic is that there are so many agents which are very commonly used as an outpatient in the hospital, in ICU, like your simple like antihistaminics, TCAs. I mean, I know we don't use TCAs as much as we used to do before. I mean, we are now doing more our SSRIs, but still, like, I mean, we do come across patients who are on amitriptyline, which is one of the tricyclic agents, and then, I mean, antipsychotics. So all of these, which are so commonly used, have anticholinergic effect. And just telling you the side effects. I mean, centrally, what happens is like you have altered mentation, depression, and few interesting features like their speech pattern. I mean, so if you are rounding in the ICU, you have an elderly patient and coming in with different symptoms like pneumonia or acute coronary syndrome. I mean, they may be on some of these triggering agents like antihistaminics, TCAs, and now, I mean, you are seeing like fragmented speech, repetitive picking movement, I mean, we have to keep in mind that, hey, am I dealing with drug interaction? Am I dealing with anticholinergic side effect? And this muscarinic blocking symptoms are, I mean, we have read it all the time in our med school days. Like it starts with this mnemonic: mad as a hatter, hot as hair, blind as a bat, red as a bee, dry as a bone. Bottom line is that there is basically your secretions are all inhibited, so you are not able to sweat, so you are hot, you are dry, and then you become more altered, confused. So these are basically your muscarinic blocking symptoms. I mean, just to give you a clinical picture, I mean, even your adrenergic toxidromes, patient would present with tachycardia, they may have altered mentation, but those patients, adrenergic patients, are going to sweat. They are going to have diaphoresis compared to these anticholinergic patients who are basically dry. So that's one thing at bedside. You could say that maybe these symptoms are more coming from anticholinergic than adrenergic. And management, again, nothing new. I mean, it's just going to be general supportive care. But the most important thing is to find out that, hey, I am dealing with anticholinergic toxidrome. So that's the most important thing. So getting rid of the inciting agent, supportive care, I mean, keeping them well volume expanded. And occasionally, like if you need, you may use some benzos for agitation. That's about it. I mean, you can consider physostigmine. I mean, the way physostigmine works is it basically inhibits your acetylcholine esterase, and so that you will have enough acetylcholine in your synapse, in your ganglion, and you may get some improved CNS symptoms. But it does have a lot of adverse effects. I mean, it's pretty serious adverse effects, as mentioned, like asystole, seizure. So I mean, it's not used clinically. So I mean, the reason I'm bringing this up is just for us to realize that, hey, drug interaction like this can happen, and we need to get rid of this inciting agent and support them. The second one I want to jump into is cholinergic toxidrome, and it is definitely very relevant in Nepal, because we do come across, I mean, organophosphorus poisoning, organophosphate poisoning, and this toxidrome is part of that pathway. So here we are talking about excessive stimulation of both of these muscarinic and nicotine receptors, and the symptoms are going to be, now we're talking about excess secretion, like either salivation, lacrimation, increased tracheobronchial secretion. So we are talking about excessive secretions, and basically patients, they are going to drown in their own oral or tracheal secretions. And nicotinic symptoms wise, basically, because as I mentioned earlier, in our sympathetic ganglion, preganglionic, you do have nicotinic receptors. So initial stimulation is going to cause tachycardia and hypertension, but over the course, because of this prolonged stimulation, it eventually inhibits that pathway, and now the patient is going to present with like cardiovascular collapse. They're going to be hypotensive, bradycardic, along with, I mean, your typical altered mentation. And treatment, I mean, we all have managed these patients. We all have given them like tons of atropine. Basically, atropine is the treatment. Basically, we are reversing the muscarinic stimulation with atropine. And we can also definitely use oxime to reactivate the acetylcholinesterase enzyme at the synapse. Now atropine, I mean, there is no upper limit. I mean, we all have managed OP poisoning with tons and tons of atropine. So, I mean, there have been, I mean, case reports of up to like 1,000 milligrams of atropine. So I don't think we have upper dose of atropine. And I mean, at what point do we stop? Now, I mean, in general, like we may think of like, I mean, since these patients with cholinergic toxicity have, I mean, constricted pupil, So, I mean, like pupillary dilatation and tachycardia, we may think they are the end reliable therapeutic point, but that's not the case. I mean, we have to control the secretion. So we have to basically dry them out. So our goal should be basically drying all those tracheobronchial secretions. Till then, we should go for using atropine. Now, pralidoxime, it's an oxime, and what it does is it basically binds, because these organophosphates are combining with your acetylcholine esterase, and that's why you have this excessive acetylcholine activity. So this enzyme breaks that bond and causing more acetylcholine esterase to be present in the synapse. So you can definitely do give the pralidoxime. There are some side effects, but again, it has not shown any mortality benefit. So there is no strong role, but I mean, it has been given depending on the availability. Adrenergic toxicity, basically here we are talking about excessive adrenergic activity. Now, what are the clinical scenario? Clinical scenario basically is, I mean, usage of recreational agents, like between cocaine or amphetamine or ecstasy, which is basically methamphetamine. So we do come across patients who are, I mean, altered, agitated, tachycardic, diaphoretic, and with, I mean, you check your urinary drug screen, they have some of these adrenergic recreational agent. I mean, therapeutic wise, I mean, even, I mean, our like albuterol inhaler, albuterol nebulizer, like inpatient in the hospital, like our general like COPD asthma patient, I mean, you may see signs of toxicity. I mean, we definitely see tachycardia, I mean, which is, I would not say that that's toxic, but if it worsens to like, I mean, tremor or like increased diaphoresis, then I think it's time we need to cut back or stop that. Inotropic agent we use in our hypotensive stroke patient, and sometimes we may see signs of adrenergic toxicity even with that. And we have other things like over-the-counter cough suppressants or amphetamine-like agent we use for treating ADSD. The patient may also present with adrenergic toxicromes. And just to dive a little bit into these recreational agent. Now, what they do is like they basically inhibit and they block the reuptake of the monoamines. Like for amphetamine, what they do is like they block norepinephrine reuptake, and you will have increased norepinephrine in the system. The MDMA or your methamphetamine, what it does is like it blocks serotonin. And in case of cocaine, it's the dopamine. And just to give you a clinical picture of your ecstasy, the typical presentation is like young, party going, they do ecstasy, and what it initially does is like they become extremely dehydrated. So those patients, they start drinking a lot of fluid, a lot of water, and because there is along with like appropriate ADS, there is some inappropriate ADS secretion also. So now you are basically in a situation with like water intoxication. So those patients present or brought to ED, they are like altered, obtunded, and they are like, I mean, severely hyponatremic. That's how you occasionally come across these ecstasy using patient because of water intoxication. In case of cocaine, and in case of cocaine, I mean, it's the dopamine, and I mean, we know that it does increase cardiac demand, risk of cardiac ischemia, acute coronary syndrome. So, and the culprit is just excessive dopamine because of cocaine blocking the dopamine reuptake. Clinical features, I mean, like in general, we know about it, like any, I mean, hyperadrenergic activity between like fever, agitations, I mean, altermentation, seizure, or like cardiovascular, while they are tachycardic, hypertensive, I mean, arrhythmia, like, I mean, they either sinus tach or they may be in AFib RVR, or in case of like cocaine or even not even cocaine in general, like they may present with acute coronary syndrome. And then again, management, again, I mean, there's nothing particular about it. You just like support, like you do your ABC, you do your airway, breathing, circulation, volume expansion, benzodiazepine for excess agitation, and occasionally, like in situation with cocaine or amphetamine, you can use Haldol. I mean, Haldol acts by inhibiting dopamine, so you can use Haldol for delirium or agitation. But in general, I mean, the main thing is, again, as I mentioned earlier, for anticholinergic or cholinergic, it's about, like, I mean, thinking about like drug interaction, thinking about toxidrome in mind when you come across this patient, and trying to get rid of the inciting agent, support them. I mean, that's what I want everybody to keep in mind. The fourth one is our GABAergic toxidrome. I mean, GABA, it's our, like, I mean, naturally occurring inhibitory neurotransmitter. It has our like chloride ion receptor, where the chloride ion enters the cell, it hyperpolarizes, it basically creates that inhibitory environment. And we have multiple medications which we commonly use, between benzodiazepine, I mean, occasionally barbiturate, and then we have our anti-seizure medication like valproate or carbamazepine, and in OR we have general anesthetic. So they all utilize this common GABA inhibitory pathway. And now, I mean, like, what is the clinical feature? Basically, I mean, they are becoming like hypoapneic to apneic. I mean, they are not, I mean, this patient who basically has toxidromic features, I mean, they're very breathing slowly, or I mean in very rare situation, they may be completely apneic also. And do we have an antidote for this? We do. It's flumazenil. I mean, the way it works is it binds to the receptor, and that's how it displaces other agonists, but it itself does not like stimulate the receptor. So that's the interesting way it works. Now we have to be very careful about like giving flumazenil. I mean, especially in patients who are on chronic benzodiazepine, and they come to the hospital, they are altered, and you're like, well, I mean, is this patient suffering from, like, I mean, excess benzos in the system? So if you treat them with flumazenil, I mean, you may actually precipitate withdrawal seizure, which could be life-threatening. And in other situations where you give flumazenil, you reverse the benzodiazepine effect, and now, I mean, if the patient has gone through like polypharmacy, then excitatory drug, like let's say like if the patient was doing like cocaine or amphetamine, now that adrenergic effect could be life-threatening. So we have to be very careful about using this flumazenil. My recommendation is that, I mean, what I do is, so I'm in the ICU, I get a call from the floor saying that, hey, I mean, we have a patient, I mean, with no prior benzodiazepine use. The patient was showing some delirium or altermentation. Somehow they ended up giving some benzodiazepine to maybe do some procedure or whatever. And now, I mean, there is a sudden change. Like, I mean, they are like completely obtunded, and they are very slowly breathing. I mean, they are almost at the verge of like going to cardiac arrest. I mean, hey, at that point, I mean, go for it. I mean, give flumazenil. I mean, of course, you need to again do your ABC first. If the patient needs to be tubed, you go ahead and tube the patient. But definitely, I mean, in those situations, I mean, I will not hesitate to throw in flumazenil. And I mean, sometimes, I mean, it reverses the process, and you may be able to save the patient without going through intubation and mechanical ventilation. Now, this sodium potassium channel pathway is very interesting, and I mean, we may not be aware, but I mean, there are so many different medications which we commonly use. They have the blocking effect of this of the channels. Now, again, I mean, we have to go back to our physiology days, where we are looking into an action potential, and in the action potential, so the first thing that happens is your voltage gated sodium channel opens, and that's where your depolarization starts. Now the sodium goes into the cell, you start the depolarization, and then towards the end, your potassium channel opens. So the potassium is now getting out of the cell, and then the sodium channel starts to close. So that's where your depolarization is slowing down, it stops, and then now we are into the repolarization phase. And then towards the end of repolarization, your voltage gated potassium channel closes, and then you're back to where your and what happens is your sodium potassium ATP is acts, and what it does is it pushes sodium out of the cell, potassium into the cell, and you're back to that cycle again. So this is our norm, and there are several agents we use that blocks this action potential, causing different clinical problems. So first of all, I will talk about sodium channel blocking agent. Now, in general, our common ones we use are like our class 1 antiarrhythmics, which are our like procainamide, disopyramide. Those are our class 1 antiarrhythmics, which acts via blocking your sodium channel. Now, this TCA, I mean, now we all understand why we don't use TCA that much, because I mean, it affects so many different channels. I mean, we talked about cholinergic pathway. Now we are talking about this sodium channel. It also blocks potassium channel. So it has so much of different effect on all these receptors that, I mean, we have basically switched from TCA to SSRIs. The same thing with antihistaminics. Even beta blocker has effect on our sodium channel, and then on the other hand, cocaine also affects this channel. And what happens clinically is that now in heart, in the myocyte, it basically prolongs our QRS. So if your depolarization is blocked, that prolongs our QRS, causing your cardiotoxicity, including hypotension, and centrally, because of it is affecting your action potential in the neurons, it affects augmentation as well as seizures. So that's why, like, I mean, again, the same thing. I mean, I always go back to, like, you get a call from ED, your augmentation, hemodynamic imbalance, and then, I mean, that's why don't forget to look at EKG. So please look at the EKG, not only to see if the patient has acute coronary syndrome, has acute MI or not. Not only that, but looking at their QRS, looking at their QTC. Now, in the EKG, what we are seeing is, along with prolonged QRS, we see a couple of features. In your AVR lead, you will have a terminal R wave. So if you look at that AVR lead, so you have the Q and then you have the R. So that's where that QR, I mean, you do not have S. So you will have a terminal R wave in AVR, and in the similar way, you will have terminal S wave in lead 1. So these features in the EKG will give you a hint that you are dealing with sodium channel blocking toxicity. Now, what do you do, right? I mean, of course, I mean, apart from your usual ABC, so you can give bicarbonate, I mean, between push or a bicarb drip. I mean, the way it works is by increasing the serum pH, it basically overcomes the sodium channel blockade. So there is definitely a role of bicarbonate in patient with prolonged QRS with sodium channel blocking toxicity. Now, talking about potassium channel. So if you remember from our earlier slide, now potassium channel, when it opens, it starts your repolarization. But if that channel is blocked, then your repolarization is prolonged. So basically your whole QT, I mean, not only QRS, but the whole QRST is prolonged. Now you will have features of prolonged QT, okay? And the group of medications, again, we already know: antihistaminics, TCAs, antipsychotics. Now, antiarrhythmics wise, I mean, we have class 3 and 1A. Class 3, if you guys remember, like amiodarone, sotalol, those are class 3. Some antibiotics and then some of these metabolic causes, they all can affect your potassium channel and leading to your prolonged QTC. And why are we worried about prolonged QTC? We are worried about prolonged QTC is it is a prerequisite for Torsad, or like your polymorphic BTAC, right? But not all patients who has prolonged QT, they basically end up having this like life-threatening arrhythmia. But anytime, again, you have exposure to potassium channel blocking agent, prolonged QTC, you have to be worried and you have to take action, which basically is, of course, if someone is in Torsad, polymorphic BTAC, what you do is you give MAG. But even without Torsad, if you are seeing arrhythmias, right? If you are seeing bigeminy, so where what happens is that you have a normal QRS, you have a widened QRS, you have a normal QRS, you have a widened QRS. So if you are seeing any, ventricular arrhythmias, then there is definitely an indication of like MAG. You can give a small bolus, you can do infusion, but definitely this magnesium does improve this repolarization. It prevents prolongation of your repolarization. So just a take home message from the sodium and potassium channel blocking is that look into your EKG when you are assessing altered patient. Or I know we got to look at EKG as intensivists, and keep an eye on that QRS, QTC, prolonged, go back, look at what could be the triggering agent. And then the next step is what do you do, how do you intervene for your sodium channel blocking prolonged QRS. There is a role of sodium bicarbonate, and for your prolonged QTC with arrhythmia, there is a role of magnesium. And then I want to briefly talk about serotonin syndrome. So all these toxic syndromes, basically, they are drug interactions. Okay, so they are all drug interactions. And again, I go back to the scenario in the ICU. You have a patient for different reasons. Now they are becoming more altered. They are becoming febrile. And now you are worried about, okay, so anytime we deal with patient in the ICU with fever, altered mentis, and you are like, well, this is infection, right? The first thing we think about is do cultures, start antibiotics, and sometimes we stop there. But what I want everybody to remember from this presentation, from this slide, is that we need to keep in mind about non-infectious causes of fever. And the number one non-infectious causes of fever in the ICU is drug interaction. Okay, so and after those drug interaction, serotonin syndrome is actually not uncommon. I would say, if you start thinking about, hey, am I dealing with serotonin syndrome? You may diagnose a little bit more patient. And so far, from our previous toxidrome, patient who could have presentation of fever with drug interactions are anticholinergic exposure patient, because they cannot sweat, they would have high temp. Adrenergic agents patient could present with fever and this serotonin syndrome for sure. Now, diagnosis wise, you have to, they don't even have to be exposed to serotonergic agent like now, within past 5 weeks. And if they have any of these symptoms, basically, in general, hyperreflexia, clonus, high temp, those are all features pointing towards serotonin syndrome. And then we can go through this pathway and then decide whether someone has a high probability of serotonin syndrome or not. And once, let's say, you have that patient, you have ruled out the infection, you are definitely concerned about serotonin syndrome, then you go over your medication list. Are they on SSRIs? Like commonly used medication in ICU, like fentanyl, has serotonergic property. Antibiotics like linezolid, which we are using more and more in MRSA, they have serotonergic agent. So remove the precipitating agent and then look into the severity. I mean, like how bad they are. I mean, if they are like, I mean, if the fever is not high, just some hyperreflexia, you are fine, like with supportive care, um, adequate volume expansion, occasionally use benzodiazepine if needed. But I mean, if they are critically ill, meaning that you are talking about high fever, I mean, like they are severely altered or temp is, I mean, you're talking about up to like 40, 41. I mean, along with benzos, along with treating the fever, I mean, there is definitely a role of serotonin blocking agent in these cases, and you may, I mean, you actually, I mean, when you're talking about high temp, you're talking about this patient, that patient needs to be tubed, intubate, sedate, even paralyze. So like, I mean, when it comes to, I mean, if we miss the initial phase of serotonin syndrome, and then when they get critically ill, it's a pretty bad situation. I mean, you are talking about cardiovascular collapse, you are talking about rhabdo, AKI, cardiac arrhythmia. I mean, like they can go through any of those situations. So please keep that in mind, that fever in the ICU, let's think of drug interaction. Briefly about opiate. I mean, I know like we are basically in a epidemic of opiate toxicity all over the world. Just few interesting facts. So whenever we talk about opiate, right? I mean, what is opiate? Opiate is basically a substance that originates from opium plant. And what are the naturally occurring opiate, which are morphine, opium, codeine, heroin. Those are technically naturally occurring. And opioids are substances with effect similar to morphine. I mean, I'm not talking about structure, but their effect is similar. And I'm talking about hydrocodone, I'm talking about oxycodone. Um, those are the things. I mean, in general, I mean, I know, like, I mean, we started using it for pain, and then from there it became addiction, and now it has become a big problem. So big thing is that overdose wise, right? I mean, how would the patient present? I mean, they are basically completely obstructed, CNS depression. I mean, they are like barely breathing. I mean, if you look at their pupils, pinpoint pupil. Now this pinpoint pupil, I mean, I want you to go back, and what are the other situations where you would have pinpoint pupil is your cholinergic toxidrome. So your organ phosphorus poisoning, cholinergic toxidrome, you will have a pinpoint pupil. And then here with your opiate toxidrome, would have pinpoint pupil. So definitely with these features, I mean, naloxone. I mean, naloxone works. I mean, it definitely prevents, it has prevented intubations. But again, I mean, like if you do not have access right away to naloxone, I mean, if you have a patient in front of you, I mean, just stabilize them, intubate them, protect the airway, then do naloxone, but it works. So far, I briefly went over our toxidromes, and again, I mean, I again want to hammer this fact is that, I mean, I was just talking about drug interactions in the ICU or in the hospital, so keep that in mind. Now let's go into specific drugs, and I will quickly go over this common drugs or poisons. I mean, I know some of it may not be relevant in Nepal, but I mean, it's good to know. It's good to know in general, like the common drugs or poisons. Okay, so first of all, I mean, acetaminophen toxicity. I mean, we all know about it. I mean, it is very, very common all over the world. I mean, we know about the toxic dose. We know how it is metabolized between conjugation, but we are always interested in this cytochrome P450, which basically metabolize acetaminophen into your intermediate toxic agent called NAPQI. And eventually this NAPQI is metabolized by glutathione. So at a normal physiological level, we have enough cytochrome P450, we have enough glutathione, so we do not have any excess NAPQI accumulation in our system. But in case of overdose, it could be chronic accumulation, it could be acute and chronic, or it could be acute. So we could have any of those three scenarios that leads to acetaminophen toxicity, where your cytochrome P450 is saturated, where your glutathione is used up, and then you end up with this toxic NAPQI. And what happens is that, I mean, your central lobular lobular necrosis is the initial feature, because that's where you have all your cytochrome P450. So that's where the damage happens. And the common clinical features, I mean, the patient will present with like nausea, vomiting, and then if they delay coming to the hospital, then I mean, within 24 hours, you are starting to see coagulopathy. Close to day 1 to day 2, you are talking about elevated transaminases, and then by day 5 to day 7, patient is in like acute liver failure, which of course it's by that point it's going to be almost point of no return. Now, just quickly reminding the definition of acute liver failure, right? So in acute liver failure, so there are a few things we need. The patient should not have cirrhosis, patient should not have chronic liver disease, and usually we talk about within last 6 months. So we can go all the way back to last 6 months, and what we need is we need coagulopathy and we need encephalopathy. So when we have these features, we say that someone is in acute liver failure. Now, in general, I mean, management, we all know, we check level, we follow our nomogram, and then we can do activated charcoal as long as it's early on, like ideally within an hour of ingestion, well, if they come. And we need a secure airway, because, I mean, if the patient is altered, then there is a high risk of vomiting, aspiration. We don't want that. And NAC, or our like antidote N-acetylcysteine, is our go-to medication. I mean, ideally, if it can be given within 8 hours, the liver damage is unlikely. But I mean, but the time doesn't matter. I mean, like we are going to use a NAC no matter what. I mean, as long as we have all the levels and everything. And what NAC does is it basically replenishes glutathione stores, as well as it detoxify P450. So so for Tylenol toxicity, I mean, again, the big thing is that the patient may give history saying that, yeah, I took acetaminophen, I took, I mean, citamol, paracetamol, or Tylenol, whatever. So they may give you history, or like, I mean, you have this abdominal pain, you are checking labs, I mean, you are seeing, I mean, abnormal coags, you are seeing abnormal LFTs, and then, I mean, like, then you will realize that, yeah, I need to check a diet, take acetaminophen level, and then start the NAC treatment. Now the take-home point I want everybody to from this slide is that we need, I mean, in general, so I mean, here we commonly use IV N-acetylcysteine. I mean, I know we can do oral, but I mean, but IV is easy to use. And the whole idea is that now the IV dose works like this. You give 150 milligram per kilo for first hour, and then you do 50 milligram per kilo over 4 hours, and then you do another 100 milligram per kilo over next 16 hours. So about 21 hours infusion. But we should not stop at 21 hours unless we have few things like your acetaminophen level is undetectable, your liver enzymes are nicely trending down, and your coagulopathy and lactate is improving. But if you still see that your INR is up, your lactate is up, you should continue the NAC infusion. And then I want to remind everybody about our referral to Liver Transplant Center. So I know we have this King's College criteria. Basically, I mean, what it goes with is it goes with metabolic acidosis. So you get a gas. I mean, of course, with any suspected poisoning, anything, we need a blood gas. So especially in acetaminophen toxicity, you get a blood gas pH 7.3 and below, means that we are, I mean, primarily metabolic acidosis, which in this case, again, it's going to be primarily due to generation of lactate. So if we are at that level of below 7.3, the recommendation is that patients should be managed at a transplant center. Or if we are having worsening coagulopathy, worsening AKI, worsening encephalopathy, or to be honest with you, I mean, like you get a SM infant toxicity, you are managing that patient. I mean, like you don't even have to wait several days. Like, I mean, let's say by day 2, I mean, like you have already started your N-acetylcysteine, but your over clinical picture, your numbers. I mean, INR even doesn't have to be 6.5. INR is trending up from 2 to 2.5. Serum creatinine slowly trending up. I mean, if those numbers are going up, I mean, we need to call transplant center saying that, hey, I mean, I have this patient. I mean, I think this patient should be better managed over there. So, I mean, I would pick up the phone and make a phone call and let them aware that I have this patient. And before things gets late and they might say that, yeah, I mean, I cannot do anything. So before it gets too late, I think it's a very good idea to involve the transplant center early on. Now, I was going to talk about ethylene glycol toxicity. I mean, I know we see this toxicity here from time to time, but I'm not sure. I mean, like how often we see the ethylene glycol toxicity in Nepal.
Yeah,
But
we also see it quite few, like from the coolant and car use. It's there.
okay,
It's not rare.
okay, good. I mean, the same thing. I mean, exactly. We also, I mean, it's not like very common, but from time to time we do. Good. So I just want to like just give like a clinical picture of the ethylene glycol. So I mean, yeah, it's present in this. It's an antifreeze, so present in this coolants. So goes in. I mean, it gets basically metabolized by alcohol dehydrogenase to glycoaldehyde, and then aldehyde dehydrogenase breaks it into glycolic acid, and then it gets broken down further, and the end product is oxalic acid. And each of these compound, each of these metabolite has its own clinical significance. So first of all, ethylene glycol and aldehyde, these two agents are going to make a patient altered. So this glycol and aldehyde, they are going to make the patient altered, and these are the reason the osmolar gap is high. And when we reach the glycolic acid, when now we are talking about high anion gap acidosis, so now we are talking about unstable hemodynamics, hypotension, we are talking about end organ dysfunction, and then this oxalic acid, oxalate, which basically precipitates in renal tubules, eventually causing your acute kidney injury. So each of these metabolites have their own role in basically worsening condition of the patient. Clinical feature, I just told you, CNS depression happens from those glycol and aldehyde, and then end organ dysfunction starts by accumulation of acidic metabolites, and then eventually we are talking about ATM and oxalate-induced nephrotoxicity. Actually, the management of ethylene glycol and methanol, I know I'm going to talk about methanol also, it's almost the same. So just to give everybody a clinical picture. So these patients with this toxic alcohol, right? I mean, ethylene glycol and methanol, they are our toxic alcohol. So the way they present is, I mean, they are going to come, I mean, either with a known exposure. I mean, everybody know that there was a group of people who were drinking, especially methanol. I mean, I know that is more common with like, I mean, cheap alcohol drinking. So they would be altered, they would be brought to the hospital, or sometimes we do not know the story. I mean, there is like an unknown person found down, brought to ED, right? So of course, the first thing we are going to do, the same thing is we are going to make sure that the airway is protected. We are going to manage those things. And then, I mean, we're going to get the blood work. And in the blood work, so we are seeing, what will we see? We will see a high anion gap acidosis. So we are going to see a high anion gap acidosis. They may or may not have developed acute kidney injury yet. And so what do we do next, right? I mean, so whenever we have high anion gap acidosis, now we have to go back to the basic. We have to figure out where those excess anions are coming from. So we have our mnemonics of mud piles, we have our mnemonics of gold marks. So basically we are thinking about, okay, am I dealing with excess glycol, excess lactate, excess acetaminophen, excess aspirin, excess ketones, renal failure? So we're thinking in those lines. So I mean, with our like renal panel, we're going to see the renal function. We're going to send a lactate. I mean, at least with the UA and history of diabetes, I mean, we will see if there are ketones in the urine or not. You may want to send a serum ketones. Those are the basic things you do when you have high anion gap acidosis. And then, I mean, like definitely please send a acetaminophen level, send an aspirin level to complete the workup. And then, I mean, like now you are like back of your mind, you are definitely strongly thinking that I'm dealing with toxic alcohol. So you are going to send for ethylene glycol and methanol, but the problem is that those tests takes days to come back, right? So what do you do next? I mean, if you're strongly thinking, if you have like this altered patient, high anion gap, now what you're going to do is you are going to do another test, which is your osmolar gap. Okay, so how do you calculate osmolar gap? Is that you calculate by what is in front of you, which is twice the sodium, and then you do BUN divided by 2.8, and then you do glucose divided by 18, and you also check alcohol. So you also account for alcohol, and then you calculate the serum osmolality, and then you send a osmolality to the lab, and then you subtract, right? You subtract the serum osmolality from calculated osmolality and look at the gap. Normally it should be less than like 8 to 10, 8 to 12. But if you have like a high osmolar gap, more than 20 or higher, with high anion gap, you are most likely dealing with toxic alcohol. And in that situation, you should go with fomepizole. Okay, so fomepizole is your it basically inhibits your alcohol dehydrogenase, and your alcohol dehydrogenase is your first step in converting ethylene glycol to glycaldehyde and your methanol to formaldehyde. So with that inhibition of first step, you are basically inhibiting formation of further toxic metabolite down the road. So you do fomepizole, and then if you already have a high osmolar gap, altered patient with high anion gap acidosis, you should probably go with hemodialysis. And then if there are other features such as, hemodynamics all unstable, altered mentation, acute kidney injury, that even adds more reason to dialyze that patient. Because you are not going to get the answer right away what I'm dealing with. But with all those clinical pictures, we should probably discuss with nephrology right there and then and try to dialyze that patient. It's the same thing. I mean, with methanol, it's going to be broken down to formaldehyde, and from formaldehyde to formic acid. And this blurred vision, right? I mean, we always hear about blurred vision, retinal toxicity, blindness with methanol poisoning. And this basically is because of local formaldehyde, which forms in the retina. And the treatment, I just told you, like, let's approach the patient as I just said about, looking into anion gap, checking osmolar gap, and then making a call about treating them with fomepizole and more than likely hemodialysis. Now let's briefly talk about salicylate toxicity. I know we use aspirin very, very commonly, and then from time to time you come across patient with salicylate toxicity. And going back to our first few slides, when I talked about our pharmacokinetic first pass metabolism, where the drugs are immediately metabolized in liver, and one of the drug is ASA, which is hydrolyzed to the weak salicylic acid. And the clinical features, so your patient is going to present with ringing ear, occasionally deafness, and they would have bounding pulse, some sweating and flushing, but a lot of times they are going to complain with ringing ear. And again, I mean, like you check labs, they are going to have high ANMF acidosis, and you are going to work up on your complete high ANMF acidosis workup. And in terms of treatment, I mean, if early on, secure airway, you're going to do lavage, activated charcoal. And here, there is definitely a role of IV bicarb. And the reason is, I mean, salicylic acid is a weak acid. So the IV bicarb, it basically, what it does is it ionizes the weak acid. So your salicylate stays in, meaning that it does not get into the CNS. It is not renally reabsorbed, so that of course it gets excreted. So there is definitely a role of IV bicarb, and I mean, ideally we try to target urinary pH up to 8, which is not always possible. So we do that, but you have to be careful because commonly this patient also has AKI and they get volume overloaded easily. So if you are getting closer to volume overload situation, definitely you got to stop volume, and then more than likely that patient will need dialysis. So again the same thing. SD recommended if high level acidemic, altered mentation, volume overload, AKI. In general, like in most of our like drug toxicity, the extracorporeal hemodialysis is recommended in general, like augmentation, cardiovascular disturbance, high level. I mean, it's a common recommendation. So I mean, we don't have to worry about what are the specific recommendation. At least as long as we keep that in mind about general recommendation, I think we will do justice to our patient. Briefly about lithium, I mean, even though lithium has a very narrow therapeutic index, but again, I mean, it is still widely used, as we all know. I mean, now more than ever, I mean, lithium is very popular for other reasons since we live in this new age of EV. Briefly about pharmacokinetics, rapidly observed, it has a wide volume of distribution. That is a problem with lithium because it does not bind to the protein and it has a wide volume of distribution, and that becomes problematic when later on when we are managing, when we are trying to get rid of lithium through dialysis. I mean, that causes problem. Long half-life, you can see, right? I mean, half-life is almost 29 hours. Toxic features. Now, common toxic scenarios are either there is a chronic lithium toxicity, acute lithium toxicity, or acute and chronic in presence of renal failure. So anytime a patient has acute kidney injury from different reason, primarily pre-renal, like volume depleted state, now you're going to see lithium toxicity, unless it is intentional and the patient has taken a lot. So neurologically, I mean, it's basically tremor, hyperreflexia. Now, just to quickly remind you about our previous clinical picture of toxidrome where you had tremor and hyperreflexia, which is serotonin syndrome. So I'm just reminding the group that, I mean, we have to keep those things in mind. Now, renal-wise, chronically, it does have a side effect, or whatever we can say is nephrogenic DI, because it basically impairs your aquaporin channels. Now, the nephrogenic DI, the way it happens is, I know they are polyuric, right? I mean, they are polyuric, but as long as they are awake and alert, they are going to drink. They are going to drink their water. So they are going to be polyuric, but they are going to maintain their sodium level. I mean, it may be slightly elevated, like maybe 144, 145, but they are not hypernatremic. Unless now, because of lithium toxicity, they are altered. Now they are not able to access water. Now those patients with underlying nephrogenic DI who are altered, now you're going to see high sodium. They are going to have sodium maybe above 150. Just to give you a clinical picture. Cardiovascular wise, I mean, again, hypertension, heart block, and some GI side effects. The worrying thing about lithium toxicity is it has a pretty high fatality, like 1 out of 4 in acute overdose. That is scary. I did mention about narrow therapeutic index, and we have all these like mild, moderate, severe, different levels of toxicity. Treatment, I mean, again, depending on when they arrive, I mean, you can do activated charcoal, but the big thing is volume expansion, because these patients are volume depleted, either from this nephrogenic DI, or maybe from GI side effects. They are definitely dry. So volume expansion is a number one way to manage lithium toxicity. And again, I mean, we always have to keep in mind, okay, when do I dialyze this patient, which would be like if they are altered, and then they have cardiac arrhythmia, if they have AKI and those levels are trending up, or their level is already high. So we have to keep those things in mind that, hey, now I need to call nephrology and plan to dialyze this patient. Briefly about hypoglycemia, and the reason I included this is that we do come across situation in the ICU like, hey, the patient is hypoglycemic, and mainly in diabetics who are already on insulin, or they may not be on insulin, they may be on like just sulfonylureas. And what do we do, right? I mean, we give them dextrose. We give them dextrose, and a lot of times we give them dextrose, patient starts eating, I mean, everything is under control. But occasionally you come across a situation where they are refractory. The blood sugar does not come up. Now, I will give an example. The typical scenario is a end-stage renal disease patient, a diabetic, who is on insulin, and they come to the hospital, let's say tomorrow, like they have a procedure or something, like they may need a dialysis catheter, tunnel dialysis catheter, something to do with fistula. So you keep them NPO after midnight. And before that, I mean, they may have received some insulin, maybe half the dose or whatever. And then in the morning, you get calls saying that, hey, blood sugar is low, below 80, below 70, because now, I mean, they are not eating. They have some insulin in the system. And now the other thing you need to keep in mind that they do not have much reserve. I mean, of course, if they have underlying liver disease also, yes, of course, they have no reserve. But even without liver disease, they do not have much gluconeogenesis going on. So they have poor reserve. So now their blood sugar drops. So what do? You give them dextrose, right? You give them dextrose, and sometimes blood sugar doesn't come up. Now, what's happening in those situations is that now those dextrose which you are pushing, it's basically stimulating the whatever beta cells they have left to release more insulin, and because of the vicious cycle, the sugar, the blood glucose is not coming up. So here there is a role of octreotide. So that's why I wanted to just keep this slide. Now, octreotide, what it does is it is an inhibitory hormone, right? So it inhibits insulin being released from beta cells. So in those situations with refractory hypoglycemia, you could manage that hypoglycemia by, along with giving dextrose, giving octreotide would help in hypoglycemia. Briefly about cyanide, I mean, I know it's not common. It's not common for sure, but occasionally in these like fire or industrial exposure, patient comes in with cyanide toxicity. What happens in cyanide toxicity is that it inhibits your electron transport chain, right? So what are the features? Like common features are headache, I know, which is very generalized symptoms. I mean, I would think someone has cyanide toxicity just by having headache or altered mentation. I mean, interestingly, I mean, like this patient, their AV, like arteriovenous oxygen difference, is less because the oxygen is not consumed in your TCS cycle. Oxygen is not consumed. So, but I mean, to do that, I mean, you need an arterial blood gas, you need like a central venous blood gas. So you need a lot of work to get this AV oxygen difference. So it's not easy to figure that out. But just in general, like, I mean, it doesn't happen always, but in but in fires or occasional industrial exposures, I mean, you may come across cyanide toxicity. I mean, like management-wise, there is hydroxycobalamin, where I mean cyanide is directly chelated. Like I mean, it becomes cyanocobalamin, and I mean there is another way where you create ferric ion via either amyl nitrite or sodium nitrite, and then it forms cyan methemoglobin, and then you give sodium thiosulfate to convert that. It's a complicated process. So in general, I mean, the easy way is hydroxycobalamin, I mean, depending on the availability. But the main thing is to keep in mind that, hey, headache, disorientation could be a sign of cyanide toxicity. That's the important thing. Digoxin toxicity, just a quick view. I mean, we use digoxin for rate control in, I mean, either in atrial fibrillation with rapid ventricular response, or like, I mean, CHF as an inotropic support. I mean, patient could be on those, and occasionally they may have toxicity either from underlying acute kidney injury causing excess digoxin in the system, and which could lead to cardiac toxicity in the form of arrhythmias, heart block. That's where the role of Fab, right? So Fab is basically, it's not a whole antibody, it's a fragment of antibody against digoxin. And the interesting thing about this is the reason we are using fragment is to prevent like any formation of antibody. So if we have a fragment, then there is less chance of formation of antibody against that fragment. That's why this Fab was brought into use. And these are the indications we can do. Just to keep in mind a few things that, I mean, if you use Fab, and if the use for digoxin was for like CHF cardiomyopathy, then you could exacerbate your low cardiac state by withdrawal of inotropic effect. Also, like if it was used to control heart rate, then withdrawal of this effect may result in rapid ventricular response. We just have to keep those things in mind. And finally, just quickly on calcium channel blocker and beta blocker, because we use it a lot, right? I mean, a lot of our patients are on calcium channel blocker for hypertension, beta blocker for hypertension, or cardiac indications, right? Now toxicity was, how would they present? They would present with bradycardia, hypotension, myocardial depression. Now, what else? I mean, what are the other conditions who could present with similar features, right? Bradycardia, hypertension. Well, I mean, if someone is hypothermic, I mean, just cold environmental exposure could cause these symptoms. Myxedema, coma would present with these symptoms. Or, I mean, like maybe just like, I mean, septic patients sometimes could present with that also. So we definitely have to keep in mind differential, but if there is a strong history that yes, patient intentionally or unintentionally, whatever way, but most of the time it is intentional in terms of this toxicity, that would be the presenting feature. One interesting way to differentiate which one is which is in your beta blocker toxicity, because it decreases your gluconeogenesis and glycogenolysis, so you would have more hypoglycemia compared to your calcium channel blocker, which basically increases your insulin resistance, so they would be more hyperglycemic. So I think that would be the closest way to differentiate the toxicity. Otherwise, I mean, everything else is more or less the same. How do you manage? I mean, again, cardiopulmonary support, volume expansion. A lot of these patients are going to need vasopressor support, like norepinephrine, and sometimes, I mean, they are going to need more than one dose vasopressor support. And there is definitely a role of methylene blue as well, which to improve the vasomotor tone. Activated charcoal. Now, in both of these, there is a role of glucagon. It has inotropic effect, as well as high dose insulin, which also has inotropic effect. So, I mean, in calcium channel blocker, I mean, insulin is not going to drop the sugar too much, but you may still have to run a D5 or a D10 by side by side, so that you don't drop sugar too much. And then if you go back to your action potential and your channel sodium and potassium, so beta blocker also affects your sodium channel. So you are going to see widened QRS in beta blocker toxicity. And if you remember, I mean, the treatment is serum alkalization. So definitely in beta blocker toxicity, there is a role of serum alkalization if you have widened QRS along with your with your insulin. And there are like rare instances where the patients are in so much of vasoplasia and profound shock that to support them, they have required ECMO. They have required VA ECMO as well. So that is like the highest level of support we can give, but that is an option if there is one. So I mean, like so far, I mean, I briefly went through, I know, so many different things, including toxidromes, including individual commonly encountered toxins. Now, general management, I have already kind of briefly included in each of the topics. Cardiopulmonary support, we all have to do. Activated charcoal, as long as they come in time, they have secure airway, and then you start thinking about hey, am I dealing with poisoning? I mean to say is there a toxidromic features? Is it like a individual drugs or toxins? And then you start thinking about has it caused secondary damage, or is there something else going on? You have to keep in mind a broad differential once you do your initial stabilization. And then once you have or once you are strongly suspecting it, you are going to go with your antidote. And then side by side, you're thinking in terms of, okay, does this patient need extracorporeal therapy in the form of dialysis? So activated charcoal, I mean, briefly, if they present up to an hour after, and multiple dose activated charcoal is helpful if the drugs which is the culprit has enterohepatic circulation, meaning that they are constantly from liver, they are going into through the bile to the GI tract, and then they are again reabsorbed. So if they are going through that vicious cycle, then having multiple doses would help. And it should be considered in certain situations like barbiturate, carbamazepine toxicity. Dialysis, straightforward indication is that if someone has a poisonous mushroom, toxic mushroom, they need dialysis. Methanol, I mean, any concern for toxic alcohol, they need dialysis. And then in other situations, depending on how their cardiovascular status is, how their mentation is, you will have to consider dialysis. Now, I mean, in general, right? I mean, how does it work? I mean, your dialysis, your solutes are going to move from higher to lower concentration. And I mean, ideally, small weight, low volume of distribution, not attached to albumin. They are an ideal, they will be cleared better. And so far, what we have talked about is, right, I mean, lithium, I mean, if you remember, if they are altered, cardiovascular toxicity, high level, they need to be dialyzed. Salicylate, I mean, the same thing, endocrine dysfunction in the form of, if they are getting into volume overload, ultramentation, dialyze. Ethylene glycol and methanol, I mean, if you strongly suspect, dialyze. Now, I did not talk about metformin, but just to give you a quick overview on metformin is that, I mean, I know we use metformin a lot. And I mean, usually once we are getting close to GFR of 30, then we need to be careful. And below 30, it's kind of tricky whether to continue that or not. But there is definitely a condition called MALA, metformin associated lactic acidosis, right? So this patient, for some reason, their renal function gets worse. Now their metformin is accumulating in the system, and then metformin definitely affects mitochondria, and now you're generating a lot of lactate, and they are in profound, I mean, cardiovascular dysfunction. So those patients, I mean, once, I mean, I know you need to make sure that that lactate is not coming from other sources, like maybe sepsis or like ischemic bowel or anything. So if everything is pointing towards metformin, then that patient needs dialysis. So we have to keep in mind that, I mean, lactic acidosis, metformin, acute kidney injury, please remember MALA. CRRT, it's a slow continuous form of dialysis. I mean, it's not our first go-to because the problem is that the clearance is low. But again, I mean, if you are dealing with a patient with like profound, shock, like there are multiple pressors, and it is like, either like a toxic alcohol or other toxins causing multi-organ dysfunction, then you may have to start with CRRT. But most of the time, we still would like to try hemodialysis, unless they absolutely do not tolerate it. Plasma exchange, I briefly want to bring this up. I know whenever we talk about plasma exchange, we are talking about a few things, right? We are either thinking about, myasthenic crisis, we're thinking of, Guillain-Barré syndrome, we're thinking of like, ANCA vasculitis, DAS, all those things. But interestingly, like the most toxic thing in the world, right? This Amanita phthaloates. I don't know how much it is prevalent in our part of the world. And these are big. They are highly protein bound. So even hemodialysis, I don't think is going to be able to remove a lot of it. So in these situations, I think there have been case reports where they have used plasma exchange. I just wanted everybody to know that, hey, Plex or plasma exchange could be used in this situation. And last but not the least, I just wanted to bring ECMO to our conversation. In very unstable patient with cardiovascular pulmonary failure, we have done everything. They are on the vent now. They have developed hearts, either from aspiration or something, and they are in profound cardiovascular failure, like in calcium channel blocker or beta blocker toxicity. Depending on how the rest of the end organ is, how everything else is, ECMO could be considered, and especially it has been used in calcium channel blocker, beta blocker, carbamazepine, and tricyclic antidepressants. So it has been used, but again, it depends on, do we have it? Is it available or not? So, but even before reaching to this point, we can do so many things to help patient before we come to this point. So with this, I would like to stop this presentation, and please, if there's any questions, let me know. I'll try to answer.
Thank you, Dr. Subhas, for a nice presentation on so many poisonings. I think now the floor is open for questions. So if you have any doubt regarding presentation or any other thing, I encourage you to ask the questions. Questions, please.
Subhas, thank you for the presentation. Again, questions might come. My brief comment. Recently, again, over the last year, I've seen beta blocker poisoning a lot, and if they go in profound shock, we always have hard time managing hemodynamics, and that's something we've seen in ICU a lot. And
yes,
we don't have ECMO capacity, so pretty much we're doing high dose insulin, even intralipid, and
yes,
more or
exactly.
less.
That I forgot to mention. Yes,
So
and
you
it
got,
works. Yes.
and I would not hesitate to do intralipid, and pretty much do as high as possible in terms of I've realized managing few beta blocker poisonings is do higher level, like recommended is 0.5 to 0.5 to 1.5 units of insulin per kilogram. I usually go higher so that at least till the time we know the hemodynamics is well controlled, and then also mainly do bicarb and intralipid. Intralipid is something, high, the fat emulsion. It also helps with the beta blocker overdose and calcium channel blocker overdose. That's one thing I just wanted to bring up. So
I agree exactly. No, I think, I mean, just recently we had a case and nothing else. Like, I mean, the insulin, glucagon was not working, and the lipid it worked. And I forgot to mention the word. Thank you for reminding.
yeah, and they go into refractory shock and nothing. You are on four pressures, you are such a bad acidosis, and nothing works. That we've seen that in a few patients. So again, I would encourage going as aggressive as possible right up front, so that later on you don't deal with all of this.
Yeah, I agree. Yes, sir.
Great presentation, Subhash. Any other questions again?
Alright, Dr. Promise, Dr. Subhas, anything else like common मैले केही मिस गरेँ कि भन्नाले अब त्यहाँ प्रेभलेन्ट या नहुने केही छ भने भन्नु होला प्लिज.
So, like you all know, the cost is a factor. So they consume whatever is cheap,
Yes.
and so the common particular things we get is a rodenticide, zinc
Okay.
phosphide, and aluminum phosphide. Especially the zinc phosphide, it is very common
Mm-hmm.
in the rodenticide poisoning. And the another thing is the acid and alkali ingestion, like the harpic.
Okay.
They are also quite common. And most of them they take polypharmacy, as you've already mentioned. So
Okay.
these rodenticides are quite common because they are very cheap, easily available. Say they consume those poisoning a lot.
अनि त्यसको म्यानेजमेन्ट के छ त्यो
So
रोडेन्टिसाइडलाई
basically, it's
स्पेसिफिक केही
a
छ?
anticoagulant. Anticoagulant, oh. So if the
एन्टिकोएगुलेन्ट हो.
patient has got bleeding, then you have to give fresh frozen plasma therapy. But
Okay.
most of them they do well with vitamin K. And
Okay.
just let the poison go down, give vitamin K, and they do well.
Okay.
And अर्को चाहिँ they also have herbicide. We also have herbicide poisoning, like because of this agricultural country, you have herbicide, and unfortunately they consume herbicide.
Okay.
And the most unfortunate thing is that you don't have anything for the herbicide if
Take
they
care, man.
consume herbicide. They get only
Okay.
palliative
Thank
care.
you.
So herbicide poisoning is also quite common.
Okay. Yes.
मेरो चाहिँ एउटा कन्सर्न हाम्रोमा चाहिँ वी डोन्ट ह्याभ इन्ट्रालिपिड्स हियर पहिला चाहिँ इट युज टु बी अभाइलेबल नाउ इट्स नट अभाइलेबल सो आई ह्याड मैले त्यो च्याट बक्समा पनि राखेको थिएँ सो वाट वी डु हियर इज हामीसँग इन्ट्रालिपिड छैन भने इफ समबडी विथ बिटा ब्लकर क्याल्सियम च्यानल ब्लकर आई हेभ युज त्यो टिपिएन हुन्छ नि सो विदाउट मिक्सिङ द्याट वी हेभ डाइरेक्टली युज द लिपिड कम्पोनेन्ट अफ द टिपिएन as a source of lipid because we don't have lipid. So do you have any suggestions or any idea, like will that work or not?
I
Like
don't know.
we have,
I,
we have tried that. We have tried that few times. I have myself tried that few times because we don't have interlipid. So that's also a lipid. So we have used that lipid formulation of TPN. And in two of the patients, it had worked. Like hemodynamically, the patient got better. But do you have any idea on that?
थाहा भएन यार. I don't know, to be honest with you. That it sounds like a good point, है तर I don't know.
Anybody else have the idea or experience using that? Because we need to find ways to deal with things based on what is available, what are the resources available at our place.
Sure.
And because intralipid was there previously, but it could not be sustained. Like it's not government organizations that brings, but it are all pharmaceutical companies. Those bring the medications, and if they don't get profit, they're not bringing it. They will stop bringing it. That happens. Intralipid was stopped, I think, 4 or 5 years. Import of intralipid was stopped here. So I think it is also our responsibility to maintain that. So I think we should start prescribing like some intralipids or naloxone, flumazenils. For this is for all the people listening from Nepal. So if you start like prescribing one or two intralipid or flumazenil or naloxone, then the business people will start thinking of importing those drugs, or else these drugs will never be imported. So I think it's time that we should, like, try to get those medications. You will be surprised to see that naloxone is not readily available and it's always in shortage. Flumazenil, it's very difficult to get here unless you have some. And for public hospitals, it's difficult because it all goes through the tender process, and naloxone, like, nobody will profit from the naloxone. Nobody will apply on the tender for the naloxone. So it's all the private chemists or suppliers, distributors will bring those drugs. So I think we should also try to, because these are life-saving medications, antidotes, we should try to, get some, prescribe some, and so that they are available in our emergency cards, emergency backup drugs.
That's true.
Okay. Thank you. Thank you, guys. Thank you.
One quick, comment
I
on.
think we have few questions from the floor. So on their behalf, I can ask you. So Dr. Subhash, there is a question from the floor that whether you use the methylene blue just for the stability of the poisoning case. Any use of methylene blue to hemodynamically stabilize your patient? What is your experience?
I mean, my
This is
experience,
from
like
Rupert.
I have, um, I think mainly like, I mean, so far, like I have used a couple of times. And one was definitely in a poisoning where, I mean, the patient was already on like almost 4 different pressors, and the patient was still profoundly hypotensive, and it was like distributive. I mean, like vasopressic distributive. That's where I used methylene blue, but I mean, but of course, the end result, patient didn't survive. Number one. Number two, just recently, I mean, overnight, we had a cardiac patient. I mean, that patient, I mean, it was a mess. I mean, that patient had a severe aortic stenosis. That patient went for a trans-aortic valvular replacement by our CT surgeon. And then during the procedure, patient immediately became shocky. And basically, this patient had like a free ventricular wall perforation and had a tamponade. So they did an open sternotomy. They did a pericardial window. They put the patient right away on a bypass and repaired that hole. And but eventually, what happened was, with all that blood products volume hypotension, the patient went into like profound shock. I mean that hemorrhagic component was better because the bleeding was stopped. But now the patient was coagulopathic in DIC, ischemic shock liver. So, and the patient was on like multiple pressors, and we added methylene blue also, like a Hail Mary, like we're throwing everything. And eventually the patient this morning passed away. So, I have definitely tried methylene blue. So I'm using it as like a 4th or 5th agent in this distributive shock. Not exactly septic, but like I'm definitely like primarily a couple of times intoxic. One time, I had no idea what this patient was going on. The patient was just hypotensive, and I just couldn't figure out what the hell was happening. So I threw methylene blue in that case also. And unfortunately, none of my patients survived, to be honest with you. Like I've used it in 3 or 4 patients. That's my experience. But I think like now we are coming more and more with using methylene blue maybe a little earlier on in our distributive shock. I think that's what is coming up in general, like studies, clinical studies wise. But my experience has not been good, because I think by that time, the whole process of end organ dysfunction, multi-organ failure has set in, and no matter what you do, the patient was not going to survive.
Thank you. There's another question from the floor.
Dr. Promise, we have experience with methylene blue. We have used methylene blue even IV and orally also. Basically in many patients with vasoplasic shock, but few, I think 1 or 2 we have used in overdose also. I think it was beta blocker or a calcium channel overdose, amlodipine overdose, I think so. And it had worked. Like when patients was on were on 3 iron tropes, and then still vasoplasic and in shock, we added methylene blue. Previously, we used to add oral also. Like when we didn't have IV methylene blue, we got the methylene blue from the oral and calculated dose, and even had given through NG. A few times it had worked. At least it has helped to maintain the blood pressure for a certain time, and now it has been made available IV also. And I think in few patients, definitely in some vasoplasic shock, it has worked. And I think one patient did well with methylene blue, and I think that patient survived. So I
Okay.
think it works in some patients,
I
not
agree.
maybe as with other drugs, not in all the cases, you know.
No, I agree. I agree. I think like we are keeping that in mind more. I mean, previously I was not, but now I'm definitely keeping methylene blue in mind when I'm dealing with like primarily distributive vasoplasic shock. Yes.
We used it in nitrobenzene poisoning, and we published a case report of that also.
Oh, nice.
So the another question from the floor is, what is the role of charcoal hemoperfusion in poisoning? Is there any role of charcoal hemoperfusion in poisoning?
I mean, there is a role of hemoperfusion. So basically, I mean, what it is that you it's an extracorporeal therapy like dialysis, but of course there is no solute moving from the higher end to lower end. But here, that charcoal basically absorbs these toxins. But the problem is that, I mean, there is a lot of side effects. I mean, there is a lot of consumption of your platelets. The patients are thrombocytopenic, a lot of allergic reactions. So, I mean, I mean, definitely it was used before, but I mean, at least here, I mean, we do not use it. I mean, I during my training in nephrology and over the course of time and looking at other studies, I mean, we have not used it because of this different, like, I mean, bioincompatibility, allergic reaction, thrombocytopenia. But I mean, in the past, I mean, it was used. I mean, there was a role. I mean, maybe they are coming up with more biocompatible membrane that I do not know, but we do not use it. That's my answer.
Okay, there's another question from Dr. Om Prakash, whether you have any quick screening for tox if you have case of unknown poisoning and you are in diagnostic dilemma. Is there any quick tox screening method or available? That was his question.
Yeah, I mean, like we have, like what we do is we check urine tox screen, and that urine tox screen gives about 9 or 10 different molecules. I mean, which basically, I mean, some of it, which are on top of my head, are like, I mean, cocaine, amphetamine, even TCAs, like, I mean, opiates. So, and I mean, and there is like fentanyl. I mean, I know it is part of opiate, but so it is like a standard. I'm just saying that it is a standard urine drug screen. We send it, but of course, if the patient is anuric, ESRD, I mean, I cannot do that. Um, and then uh, and then what I do is, like, as I was mentioning about the high anion acidosis, I do my workup, like checking our like salicylate, I mean Tylenol, I mean lactate, ketones, and then toxic alcohol depending on the situation. But to answer the question, yes, I mean we have the urine drug screen checking about 10 different molecules.
Thank you, thank you. Thank you, Dr. Subhas. If
Yes.
there are any questions, you can ask. Otherwise, I think now we'll close it.
Hmm?
Thank thank you, Dr.
Promise, there is
Subhas, for
one
a
more
one.
question in the chat box.
Okay, thank you. So the question is that whenever you are treating a salicylate poisoning, do you deliberately target urinary pH and try to excrete it? So that is the question.
I mean,
Target
that's the,
urinary pH management in salicylate poisoning.
I mean, again, that's the idea. Like, as I said, that, I mean, definitely, I mean, of course, the first thing is you do volume expansion, and then there is a role of bicarbonate. So having a bicarbonate drip is preferable because it being a weak acid, and I mean, if we can break it down to an ion form, it will not be absorbed back into the urine. So that's the idea. And I know I mentioned that we target. Yes, I mean, like, we keep a goal of urinary pH of 8. Now, to do that, like, let's say, right, I mean, so when we order a bicarbonate drip, so that bicarbonate drip will be like 150 milliequivalent of sodium bicarbonate, I mean, either in a free water or in a dextrose. So that is the max you can do, which basically gives us a sodium concentration of 150 millimole per liter. And I mean, so to achieve that urinary pH of 8, I mean, so where do you start? You start 100 ml per hour, 125. I mean, you can go up, but I mean, what I want to make sure is that you make sure you are not overloading the patient. So yes, I mean, yeah, ideally, like, I mean, you are going to check the urinary pH. So do not forget, I mean, check urinary pH today in the morning, and then you have started a bicarb drip, check it in the afternoon or evening. At least make sure that that urinary pH is trending up. If it was like 5 to 6 to begin with, I mean, if it's going up, right? I mean, from 6 is up to 7, and now, I mean, your drip is up to like what, like 150 or so, and then, I mean, you are getting into the phase of volume overload. Then, I mean, I would not want to go. I don't care about targeting 8 at that point. I mean, now I have to think about, like, I'm slowing down on the drip. I mean, you may have to diuresis the patient because they are in pulmonary edema, or they may, I mean, now, I mean, I may have to dialyze the patient. So the answer is yes, you follow the trend. Yes, I mean, ideally, bringing that pH up to 8 urinary wise would definitely help with urinary bicarbonate or urinary salicylate excretion, yes, but you have to look at other factors also.
Thank you, Dr. Subhas. I think now we'll close the session. So I'd like to thank Dr. Subhas Regmi for his valuable time and all the knowledge sharing. I'd also like to thank American Nepal Medical Foundation for making this happen. I'd also like to thank Subhas sir from Teaching Hospital for coordinating all the things. And I'd also like to thank all the participants for the active participation. Thank you. So, Dr. Subhas, I think we'll close the session today.
Yes, thank you very much. It was really good discussion, and we should keep doing this. And I know Naveen is actively working on getting this to be continued. So thank you, Naveen, on your role also. Thank you.
Thank you. Thank you. I think we'll close it. Thank you.
Thank you all. We'll stop it.